Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove handy in your line of duty. So I welcome you to part 81 of our Pharmacotherapy MCQ series, which measures in basic oncology. And our first question reads, Mr. TGG, a 51-year-old male patient, presents to the oncology clinic with flank pain, hematuria, and he has a palpable abdominal mass. You establish that he drinks 5 to 6 bottles of beer on a daily basis at dinner time, and he loves eating junk food at fast food joints and restaurants. He has a past medical history of congestive heart failure, hyperlipidemia, and type 2 diabetes mellitus. Your clinical oncologist does a diagnostic workup which confirms Mr. TGG has renal cell cancer or renal cell carcinoma, RCC. So my question to you is, which of the risk factors listed below is associated with renal cell carcinoma or cancer? Is it fatty food consumption, obesity, alcohol consumption, or hyperlipidemia? I'll give you 10 seconds to choose the correct answer. Obesity it is. Obesity is a risk factor for RCC, and studies have shown that patients with BMIs of equal to or more than 26 have about 90% higher risk of having RCC. The other options, in my opinion, are incorrect. They haven't been adequately studied to show increased risks of RCC. I would like to add that alcohol consumption can increase risks of hepatocellular carcinoma, while fatty food consumption can increase the risks of having colorectal cancer. So those many words make me biased towards alternative B, which is obesity. Let's move to the next slide, please. And it reads, Mr. KJM, a 75-year-old male patient, presents with stage 4 non-small cell lung cancer, what we abbreviate as NSCLC, to your oncology clinic with bone metastasis. He has a past medical history of 45 years of smoking. He drinks 4 to 5 bottles of beer on a daily basis. Your oncology team decides to treat Mr. KJM's cancer with chemotherapy. So my question to you is, which of the factors listed below is or are associated with the reduced risk of hematogenic potential for Mr. KJM? Is it smoking history, age, and his male gender? Is it his age, his male gender, and alcohol history? Is it his male gender, alcohol history, smoking history, or is it his alcohol history and smoking history alone? I'll give you 10 seconds to choose the correct answer. It is his age, his male gender, and alcohol history. Now, older patients are at a lower risk of emesis compared to younger patients. And then males are at a lower risk of emesis compared to females. And then alcohol use reduces the risk of emesis. And smoking hasn't been proved to have significant impact on patients' risks of emesis. Now, other risk factors for nausea and vomiting include a history of motion sickness, a history of morning sickness, a history of nausea and vomiting, an environment in which chemotherapy is administered, the dose of the emetogenic agent, and even efficacy of the anti-emetic regimen used. So all those many words justify why age, gender, and alcohol history is the best option in this particular question. Let's move to the next question, please. And it reads, Mrs. MJK, a 36-year-old female patient with stage 4 Hodgkin's disease, attends your oncology clinic and has already received 3 cycles of ABVD, doxorubicin, bleomycin, vinblastine, and dacarbazine regimen. She is scheduled to receive the 4th cycle of therapy today, and the oncologist does a chemotherapy toxicity evaluation and notes that she presented with significant cough, dyspnea, and tachycardia. Further workup, that is pulmonary function and scans, revealed she has interstitial pulmonary fibrosis. So my question to you is, which of the chemotherapeutic agents listed below is the most likely cause of Mrs. MJK's lung injury? Is it vinblastine, dacarbazine, bleomycin, or doxorubicin? I'll give you 10 seconds to choose the correct answer. Bleomycin it is. Now, bleomycin is known to cause pulmonary toxicity, which is dose limited, and it can also cause bleomycin-induced pneumonitis, to be specific. Now, development of pulmonary toxicity is thought to be caused by endothelial damage of the lung vasculature due to cytokines and free radicals. Now, I would like to add that doxorubicin's primary serious adverse event is cardiotoxicity. And then vinblastine primarily causes neuropathy and myelosuppression. Then dacarbazine may cause prolonged myelosuppression. So none of them fits this particular case that we are tasked with. I would just like to add that bleomycin-induced toxicities occur predominantly in the lungs and on the skin. Those particular organs or tissues lack bleomycin inactivating enzyme, which is called bleomycin hydrolase, that we talked about in one of the previous sessions. All those many words make bleomycin the right choice. Answer C is the correct one. Let's move to the next question, please. And it reads, Mrs. FJY, a 47-year-old woman with breast cancer, is currently receiving doxorubicin and cyclophosphamide chemotherapy. She complains to the medical oncologist about nausea and vomiting from her chemotherapy, and the oncologist prescribes palonosetron, dexamethasone, and fosaprepitant, which he hopes will provide the best chance for preventing acute nausea and vomiting. So my question to you is, which of the statements listed below is true about this particular choice? Is it, I agree with the choice, but the patient is at risk for more vomiting than nausea? Or is it that I agree with the choice, but the patient is at risk for more nausea than vomiting? Or is it true that I agree with the choice? This will provide equal prevention of nausea and vomiting? Or is it I disagree, fosaprepitant isn't needed in this patient's case? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. Now FJY is at a high risk for acute and delayed emesis since she is a breast cancer patient under the age of 50 years receiving an anthracycline co-administered with cyclophosphamide regimen. Now the use of fosaprepitant, which is marketed as Emend, is recommended in Madam FJY's case. I would not omit it. Now historically, the incidences of nausea and vomiting are not found equally. A trial with an antiemetic regimen similar to the above resulted in nausea incidences of approximately 60% with acute emesis of about 20%. Now the communication to the patient should include prevention of emesis is achieved in the vast majority of patients, but nausea control can be challenging. Yeah, that's why I say the patient is more at a higher risk of nausea than vomiting. It's easier to control the vomiting than the nausea. Let's move to the next question, please. And it reads, Mr. ABC, a 43-year-old man, was recently diagnosed with diffuse large B-cell lymphoma. Your oncology team intends to start him on R-CHOP therapy, which is rituximab, cyclophosphamide, vincristine, doxorubicin, and prednisone. Some of his pertinent labs include a BUN of 22, serum creatinine of 1.3, uric acid of 6.5, phosphate of 4.4, LDH of 333, potassium of 4.4. So my question to you is, which preventative therapy should the oncology team begin immediately? Should they administer allopurinol, rasburicase, Mesna, or calcium acetate? I'll give you 10 seconds to choose the correct answer. So they should administer allopurinol. Now allopurinol is a xanthine oxidase inhibitor that prevents the formation of uric acid. It should be started immediately in patients at a risk of tumor lysis syndrome, TLS. Now patients with rapidly dividing malignancies like certain types of leukemias, e.g. the AML, and lymphomas such as Burkitt's lymphoma and even diffuse large B-cell lymphomas are at a risk of tumor lysis syndrome. So that makes it highly recommended. I would like to add that the LDH is a good marker that depicts tumor burden and may provide a hint of the patient's TLS risk. Now, since ABC's LDH is elevated and he has a diffuse large B-cell lymphoma, he is at a risk for tumor lysis syndrome. Now, if ABC's uric acid was over 10 milligrams per deciliter along with renal dysfunction, then the use of preventative rasburicase would have been indicated. I would like to add that all patients at intermediate or high risk for TLS, with the exception of those with renal failure or oliguria, in my opinion, should be given adequate hydration for the prevention and the treatment of TLS, with the goal of maintaining equal fluid intake and urine output. We should avoid volume overload. Then rasburicase quickly converts uric acid to allantoin, which is renally cleared. Now I would like to add that mesna, which is alternative C, isn't given with the SHOP regimen, and calcium acetate, alternative D, is a phosphate binder. It may be started if a patient's phosphate level appears elevated when we do the labs. So all those many words make alternative A, allopurinol, the best answer. Let's move to the next question, please. And it reads, to which of the IgG monoclonal antibody groups or classes does Panitumumab belong? Does it belong to the mice or mouse, human, humanized, or chimeric type? I'll give you 10 seconds to choose the correct answer. Human is the correct answer. Now, Panitumumab, which is marketed as Vectibix, is a recombinant, fully human IgG2 kappa monoclonal antibody that binds to epidermal growth factor receptor, what we call the EGFR, and is mainly used to treat metastatic colorectal cancer. Now, the monoclonal antibody MAB nomenclature depicts the suffix, that is U, the U letter refers to a human source. Then the suffix AMAB depicts a murine source, 100% mouse. Then the suffix XMAB depicts chimeric form, which is 67% human in the FC regions and 33% mouse in the variable region. And then the suffix ZUMAB depicts a humanized only, which is 5 to 10% mouse in the complementary determining regions. Now, recognizing the chemical composition of the monoclonal antibodies being administered to the patient is very clinically relevant in terms of tolerability and even risk of adverse reactions. Now, I would like to emphasize that biologic products that are more human will less likely be rejected. They'll be better tolerated as compared to those other sources. Let's move to the next question, please. And it reads, which of the medications listed below isn't an aromatase inhibitor used in estrogen receptor positive breast cancer? Is it letrozole, which is marketed as Femara? Is it toremifen, which is marketed as Fareston? Is it anastrozole, which is marketed as Arimidex? Or is it exemestane, marketed as Aromatase? I'll give you 10 seconds to choose the correct answer. So toremifen it is, Fareston. Now anastrozole, which is Arimidex, and exemestane, Aromatase, and even letrozole, Femara, are what we call the third generation aromatase inhibitors. Now both anastrozole and letrozole are selective non-steroidal competitive aromatase inhibitors, while exemestane is a steroidal aromatase inhibitor that binds to the enzyme. Now toremifen is a selective estrogen receptor modulator, what we call a SERM, S-E-R-M, just like tamoxifen is. So all those many words make me settle for B as the correct answer. Let's move to the next question, please. And it reads, Mrs. TSW, a 66-year-old female patient with a 60-day history of postmenopausal bleeding, presents to your gynecologic clinic. Her menstrual cycle started at the age of 11 years, and her last cycle was 10 years ago. And Madam TSW has a 15-year history of oral contraceptive use and remains childless. She's never given birth, and she has a past medical history of type 2 diabetes mellitus and hyperlipidemia, and in the past she smoked or used tobacco for 20 years. So my question to you is, which risk factors for endometrial cancer are present in the case of Mrs. TSW? Are they obesity, early menses, type 2 diabetes mellitus, and smoking? Or is it obesity, age, early menses, type 2 diabetes mellitus, and smoking? Or is it obesity, early menstruation, late menopause, and type 2 diabetes mellitus? Or is it age, obesity, the use of oral contraceptives, and smoking, and even nulliparity, the fact that she's not given birth? I'll give you 10 seconds to choose the correct answer. D is the correct answer. Early menses, obesity, late menopause, and type 2 diabetes mellitus. Now, risk factors for endometrial cancer include the following: increased estrogen levels, which are associated with the obesity, type 2 diabetes mellitus, and a high fat diet; nulliparity, early menstruation, late menopause, what we call the Lynch syndrome, LYNCH syndrome, and even older age, that is equal to or above the age of 55, and even tamoxifen use. I would like to comment that oral contraceptive use has been associated with a decreased risk of endometrial cancer, and there is a positive correlation between the duration of oral contraceptive use and its protective benefit. It's quoted in literature. Then smoking hasn't been associated with an increased risk of endometrial cancer. Then the primary cause of endometrial cancer is excessive estrogen exposure caused by, for example, obesity, type 2 diabetes mellitus, and even a high fat diet, which leads to an increased endometrial proliferation. Then other factors include nulliparity, as I said, early menstruation, late menopause, genetic mutations, older age, and even tamoxifen use. So I would just like to add that endometrial cancer is the most common gynecologic malignancy in the US, and obesity is more significantly associated with the development of endometrial cancer than any other cancer type among the ladies, the women. Now, in the United States of America, approximately 57% of endometrial cancer cases, I read somewhere, are attributed to being overweight and obese, and reducing the risk of obesity can decrease the risk of endometrial cancer, just as a by the way. Let's move to the next question, please. And it reads, which of the BCR-ABL TKIs isn't or aren't appropriately matched with its or their corresponding toxicity or toxicities? Is it Nilotinib and QT prolongation? Is it Bosutinib and Pancreatitis? Is it Panitumumab and arterial thrombosis? Or is it Bosutinib and pleural effusion? I'll give you 10 seconds to choose the correct answer. mismatch is in alternative B, Bosutinib and Pancreatitis. Now we know that Panitumumab and not Bosutinib has been associated with pancreatitis. Now, Panitumumab has a black box warning for arterial thrombosis and hepatotoxicity. Dasatinib is associated with pleural effusion, and Nilotinib has a black box warning for QT prolongation. While all of the BCR-ABL TKIs are relatively well tolerated, the differences in their toxicity profiles should be considered by clinicians when selecting an appropriate drug for each patient. According to the NCCN guidelines, Nilotinib or Bosutinib may be preferred for patients at risk of developing pleural effusion or with a history of lung diseases. And then Dasatinib or Bosutinib may be preferred in patients with a history of arrhythmias, heart disease, pancreatitis, or hyperglycemia. Let's move to the next question, please. And it reads, in which of the clinical scenarios listed below would empiric vancomycin usage in a febrile neutropenic patients be considered appropriate? Would it be a case of cellulitis with an absolute neutrophil count of below 100 or pneumonia? Or would it be a case of penicillin allergy, cellulitis, or low blood pressure? Or would it be a case of cellulitis, low blood pressure, or pneumonia? Or would it be a case of absolute neutrophil count of below 100, cellulitis, or line infection? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer, cellulitis, low blood pressure, or pneumonia. I would like to start by saying that empiric vancomycin therapy for ALL febrile neutropenic patients isn't recommended. Now, vancomycin or similar spectrum agents should be considered if the patient exhibits a suspected or confirmed CVC-related infection, skin and soft tissue infection, pneumonia, or hemodynamic instability. So those many words make C the correct answer. Let's move to the next question, please. And it reads, which of the listed common adverse effects from EGFR inhibitors can predict an increase in response rate and survival? Is it interstitial lung disease, rash, diarrhea, or anemia? I'll give you 10 seconds to choose the correct answer. So rash it is. Now, EGFR inhibitors like Nilotinib can produce an impressive acneiform rash that may correlate with response and survival for a variety of tumors. If a patient presents with an unthreatening rash, clinicians typically treat through the rash to ensure the patient continues to receive the drug. Severe life-threatening rashes will require a temporary or permanent cessation of therapy. Just as a by the way, let's move to the next question, please. Which reads, Mrs. J.A.P., a 48-year-old female patient with confirmed breast cancer, is scheduled to receive doxorubicin alongside cyclophosphamide. My question to you is, how would you rate the risk of causing a mesis in this chemotherapy regimen? Is it moderate, that is 30 to 90%? Is it high, that is above 90%? Is it low, that is 10 to 30%? Or is it minimal, below 10%? I'll give you 10 seconds to choose the correct answer. I would rate it high, above 90%. Now, breast cancer patients receiving anthracycline and cyclophosphamide, that is doxorubicin and cyclophosphamide containing regimens, are at a high risk of emesis. Now, breast cancer patients are considered a higher risk population because of their female gender, their higher anxiety, and even in cases of ages below 50, considered a risk. Now, these patients should be receiving what we call the 5-HT3 receptor antagonists alongside dexamethasone and aprepitant containing regimens to prevent nausea and vomiting. Just as a by the way. So, my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel, and I would like to promise you all that the very best is yet to come. I would like to thank you very, very much for viewing this video and for listening to me. And I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in the next part of our MCQ series. Thank you very much.